Here as well as some of my friends. So it's so good to see everyone. But the work I'm going to be talking about tonight is called Health Commons. And so with my colleagues here too, I just want to say that nothing happens in a vacuum. So they're all part of this work as well. I've just happened to be the one who's been doing it the longest. So if they have anything to interject, please do so, everyone. Katie Martin, Amy Nelson, and Brooklyn Loxer-Camp are all here. So anyhow, I just kind of want to start with that. And also, I love being super informal. So if there's a question that you want to ask when I'm talking, please feel free to interrupt at any time. But I'll share my screen. Everyone see that okay? All right, good. So, like I said, we're going to be talking about the Augsburg Health Commons and a little bit about what that model of practice is that kind of grounds the work that we've been doing. So we'll go over what a health commons is, and again, kind of that model of practice, and then kind of think about the different ways we've tried to evaluate the processes measuring student learning in this moment. I should say that I have been a professor at Augsburg for 16 years, and I am now the chair of the department and the executive director of our health commons. So I came to this work as a student. I went to Augsburg, got my master's and my doctorate in transcultural nursing leadership, and I never left. I've tried a couple times, but I couldn't get away. So, anyhow, and then kind of describe some of the current issues and opportunities for the profession while we're carrying in the margins. So this is a picture kind of back when we started. So the original Health Commons, there's multiple locations, but I'm first going to talk about the original site just because it's kind of easier to understand that way. But it started back in 1992. And the chair at that time was really thinking about what's our responsibility to respond to this modern day homelessness. So at that time, we were seeing like the results of deinstitutionalizations of mental health facilities, the war on drugs, the increase in HIV/AIDS, the crack epidemic, amongst many other things that we're all really familiar with if you're especially thinking about history. And so she really questioned what is it that we should be doing in these moments. And so with that, at that time, there was often these nursing centers, which not a lot of them still are around, and most of them have turned into third-party payer systems where they're federally funded community clinics or other clinic models for that way. But anyhow, so she really was asking this question. And with that, she decided that nurses really needed to find a way to respond to the crisis of the moment and bring students in to be part of that work. And so this is our space now. This picture is actually taken, so it's at Central Lutheran Church, and they have a day shelter. So we're one aspect of the wider day shelter there. So this was taken during COVID, and you can see we have students here. So we have nursing students as well as undergrad students and PA students that are in this photo. This photo actually was taken when we were doing a vaccine pod. So because of our relationships to the homeless community and others working in the field, such as healthcare for the homeless, Hennepin County and others, we stayed open during COVID. And George Floyd had been a guest in our space, so you can imagine what that did for our community, as well as many of our unsheltered guests were told they couldn't go in anywhere, so they were forced to be in encampment. So we did stay open, and during this vaccine pod, we would go out to the local encampments and try to bring people in, since we were one of the first waves of people able to provide vaccines to the unsheltered community. So at the middle of all that we try to do is really try to think about how do we help students learn to decode structures of oppression that exclude individuals from discovering means of health. And we'll kind of get more into this as we go. But like just in general, a really quick way of understanding a health commons is it's a health focused drop-in center that faculty lead and often marginalized, whether economically or socially marginalized communities that really try to think about addressing the challenges that the community expresses. So while like we partner with others and think about, community health needs assessments and why those are important, we really try to take the aspect of coming in and asking people what it is that they want and then responding in that way. So again, this is really thinking about what grounds us and what makes us different. And so this is kind of the whole picture of the article, which has been published in various different journals, but the first one was Advances in nursing science. I'm a huge fan of Peggy Chin. Anybody who knows me knows I just love her so much. So anyhow, at the core of everything is really thinking about hospitality. So this is not just for students, but for people who volunteer, for us faculty members. So really just thinking and not about tolerating difference, but welcoming and promoting it. And so really not coming in with a pre-scripted agenda of what's going to happen in the day, but really trying to understand how we welcome without condition and really help find that common ground we all share as we're all very interconnected. And what does that mean? What does that mean to be interconnected? And I think a lot of times our students, so we at Augsburg in our nursing program, we have an RN to BSN completion program and then grad programs. And so a lot of our nurses are already working in the system. So sometimes really it's really just this place of thinking about nursing in a different way, or maybe what really brought us to it, and then we're burnt out or we are socialized to normalize blaming people for their behavior. So how can we really think about some of those things that maybe have been grounded in us that we want to think differently of and kind of dig into? So the first stage is really thinking about this acknowledgement of the need. And so people come into this space, they don't have to say their name, they don't have to have proof of insurance or proof of need. They can just come in and ask for socks. Socks used to be the way we kept track of everything, but now that Bombas gives us socks, we have more socks than we know what to do with. So thank goodness for Bombas. They are really a real good company. But anyhow, so a lot of times the student is really in this role of being a compassionate caregiver. So they're really starting to begin to acknowledge what the gravity of the need is as they're handing out hygiene supplies, socks, diapers, underwear. We do have a shower there as well. So really trying to think about exploring social justice in the way that's more maybe internal. So what are they what are they wrestling with? What biases might be coming up and all those kind of things. As we think about service that sometimes is like thinking about almost like a charity model and moving into a relationship model. And sometimes this is the place that people start when they first come in. And then the next stage is really thinking about attending to the struggle. So sometimes after people come through that first line and they ask for a pair of socks or whatever they might want, they move and they might sit down in a chair. And so a lot of times this is when we're able to have those one-on-one conversations. And so this is a picture of a gentleman who has been living in and out of detox facilities or on the streets for a very long time. And so it's a moment where we can really kind of get to understanding the complexity of the issue and begin to understand how we can get away from just having interviews and asking people an assessment, but really having conversations and really trying not to oversimplify things to fix it or doing something, but staying in that moment and hearing the story that the person is sharing. In that is really to suspending judgment because I think that sometimes it's hard. It's hard to understand how people ended up the way they are. But this person in this picture, I can tell you when I worked in the medical ICU, we had a lot of times where people would come in with liver failure, and we began to be, due to time and being burnt out and all the things, right? Sometimes you make this generalization of, okay, here's another person that's probably going to go out and use alcohol again, who might get a liver, and then they're going to come back. But not really understanding that maybe that person never had unconditional love, like how those ACEs show up that we always talk about. But what do we do about preventing those things or understanding the trauma that shows up later in life? And maybe those are the stories that people don't share readily. And so students really begin to try to really sit and authentically listen and then maybe name some of those structural inequities or even structural violence that's persisted. Another big person we read in the program is Paul Farmer. And really, I don't know if you guys have read much about him, but he is phenomenal in really just kind of unpacking this idea of structural violence in healthcare, whether it's in the US or globally. And then they kind of move into this third stage. So we really try to encourage students to really think about the strength that they're hearing because it's really hard to think about or easier to pull out the deficits, but really what is the strength? And a lot of times people can't, if they're living in the unsheltered community, for example, they can't just sit without being interrupted or, what are you doing here? So sometimes it's just a place for people just to sit and hang out. So they might get a foot soak. We have foot care on site, basic foot care. We don't have the Drummels and things like that, but just very basic foot care. Foot care has been a huge thing lately too, because a lot of our guests have been falling into this gap in care where podiatry is not reimbursing based on their insurance for doing things like ingrown toenails, or people maybe aren't diagnosed with diabetes even though they have it. And so we've been seeing more and more foot issues. And so we've really tried to respond to that because the community has asked us to. Not because I'm a foot person, but because it's really about that connection. And you mentioned so many books too, really thinking about that personal touch, like somebody's touching you, and what does that mean to somebody who often feels like they're not welcome. And so again, trying to acknowledge like maybe we have skill and opportunity in navigating academia, per se, but they really have creative maneuvers and living life on the streets. And what can we really say about that? Students also start to acknowledge their own positionality and also who's working in the discipline and maybe who should be represented more. And so hopefully a pattern of relationships and mutuality kind of surface from being in this stage of really, like I said, acknowledging the strength. And this is a place to where students really can start unpacking some of those more complex ideas and have a lot of aha moments that make them want to do more. And so the final stage is accompaniment. Again, this is Paul Farmer and amongst some others that we've been. So I didn't say this, I forgot to add this part. The model was started in 2009, and it was a group of DNP students, myself, and three other faculty members that came up with this. So it was really a collective effort to try to name what it is that we're doing there and being intentional about it. And so really walking with a person at a particular time and place, taking shared risk and solidarity, and attempting to remove the shackles constraining the origins of knowledge. And I think we talk a lot about this when we're here. Who names what knowledge is? So epistemological humility. So maybe I have gone to school for way too long and have way too many degrees, but people on the streets have the knowledge of what it is to survive. And things that I would never imagine being able to make it through. And so, really, how do we de emphasize being an expert in those conversations so we can really help the person get to their goals of what they have for their health? And so, this again is somebody that we frequently visit on the street. He has persistent and severe schizophrenia. And usually we don't get into diagnosing as much as we're trying to bridge the gap, helping people connect to resources. And if they want, helping them get into if it's treatment or a clinic or whatever they might want to be connected to. He's a person who's been coming in for a long time, and he ended up actually considering going to housing. And so he, because of these relationships at the Health Commons, let us help with, at that times it was St. Stephen's Outreach, try to get him some housing, and he didn't have an ID. And so I ended up having to call his mother and seeing if she would sign off on the paperwork for him to get an ID. And she didn't even know he was alive. And so some of these moments that you get to be here for are just kind of unreal. And then the students get to be with us in those moments as well. And so he is somebody who still lives on the street. And it is a good question for us in our profession too. Like, what is the right thing to do in that moment? Is it to force somebody who's been living on the streets for 20 years, who wants to hear the voices he's always heard and doesn't like the side effects of the medication, and let him live that way? Or is it to force him to become, a ward of the state and take the medication? And so I think we hear this a lot on the streets about what is our responsibility and what is the right thing. And I don't think I've ever heard an answer that really lets me put that wicked question to rest. So if any of you have a good answer for that, please let me know. Um, but then as we think more about what things have looked like, not so much in the last year because Well, we had a lot of turnover in the department, and then I ended up having to become chair. But for a good period of time, for we were going out into the encampments, especially when the encampments were very stable. Now, um, there's a lot of it's called sweeps. So if somebody is living outside in a tent community, often depending on whose property they are, they'll come in and be forcefully removed from where they're staying at. So then it's harder to find people. So it's harder to bring them food. It's harder to bring them water or keep connecting with them if they have wound care that they need or other basic issues. So Augsburg has been working, maybe not as much as I had originally hoped, but we've been working with the University of Minnesota and then others who are doing outreach into the homeless shelter community, trying to look at what are the correlations between overdose deaths from MDH and the encampment sweeps to try to come up with some correlation of a health outcome related to these sweeps. While at times there are issues with diseases from, not removal of waste over time if people have been there for a long period of time, but we're talking people are there for a couple days and then they move to the next place. And so like what is the response? And the response from the national level has also kind of been criminalizing sleeping outside. So it'll be interesting to see what comes of all that. And now they want us to help where we help people who are living in the encampment start interviewing people who are doing the care in the unsheltered community. So that's kind of the next level of the research that is coming. But so over time too, so this is one of our students who was with me for a year and a half, just to kind of give a brief overview of like an experience like this. So um, Isaac has shared that I can share what he has written, but I'll just give one example for sake of time. But making assumptions is dangerous. For example, I heard the story of a woman on the subway who was being sexually harassed. A bystander asked a woman why she didn't leave this man and stop the domestic abuse. She responded with, "It's better to be raped by one man than 12. Never judge a person's situation or assume to know the dynamics behind their decision making." The other one I think that stands out really well too is I think I learned to use the term mental injury rather than mental illness because an injury is a scar that someone is healing from and does not find their perpetual state like an illness diagnosis. So it was really interesting just to hear what he had to say after his time with us. So in 2009, there was a participatory action research done in the neighborhood by St. Kate's and also the U of M. And so in that, they were trying to capture why so many of the elderly East African women were having a rapid decline in their health. So when they first came to this country, oftentimes their health was seen as parallel or often better than women the same age as them who were living in the US, but then within 5 years it rapidly deteriorated. And so what they did was interviews with key informants as well as focus groups, and from that they came up with these key takeaways. And some of them were really this discordant health belief. So at home, in Somalia, when I would go to the doctor, the first thing they talk about is the Quran. And here they don't even ask me if I have a faith preference. Obviously, the cultural and language barriers can be a huge barrier as well as wanting the same gender for a care provider. Sense of time and urgency in terms of being late, and then the doctor might cancel you, but you might wait for the doctor. So some kind of like confusion around that. Clash of health norms and practices. So why would I go to the doctor when I am feeling okay? When at home in Somalia, I would only go to the doctor if I felt like I was dying. Well, and then I'd feel better right away because they were having their things like malaria or tuberculosis, right? That antibiotics could easily take care of. And then the stigma around mental health and substance use. Substance use in the Cedar Riverside neighborhood, right where Augsburg is, and especially in the high rises, has been a huge problem that's not well captured. And so they came to us and asked if we would consider using our model of practice in the Cedar Riverside neighborhood to begin another site. And so at that time, Sarah Noor was working at Fairview. She ended up being the CEO of People Center. But so her and myself, and then Dr. Osman Harari were the director of community. He was the director of community health in Somalia. We started opening a health commons officially in 2011 in Cedar Riverside. And so we have two spaces in the high rises where we are there 5 days a week. And in that same experience, when we started, a big question was Dr. Osman and I were just sitting there waiting for people to come ask for what they wanted and not trying to come in with our preconceived notions of what the community should be working on. And so in that really came out this whole like sense of social isolation or lack of available space to connect. It's said to be, I've never seen the document of it, but we say at Augsburg all the time, it's the most condensed area between Chicago and LA. And if you've been in that space, you can believe it, right? There's a lot of people there, not a lot of green space. And people came here during a time where we had September 11th happen and a lot of Islamophobia and people feeling a sense of fear leaving their community and what might happen. And so a lot of it really was this idea of social connectedness on top of really questions around food. Food is such a parallel between all these different locations. And then gardening. So we have gardening groups. We bring in fresh produce now into the neighborhood with this partnered with the Sane Foundation. All this work, I should say too, at Cedar Riverside is a partnership between M Health Fairview, Augsburg, and then the East Africa Health Project. And so we work together, but then try to collaborate with others in the neighborhood. Dr. Martin, who's in the room, she just got done having a big MDH grant working on infant health issues between research studies and classes in the neighborhood and huge parties where they would have birth celebrations and give out cribs and do traditional dance amongst other things. So we also have exercise for women, and then we do foot care in the elderly public housing units. And so we used to actually bring students as well into the different mosques every Friday, but there was some real issues with students just not understanding some cultural norms that they should if we're going to be in the mosque during prayer times. And so we kind of shied away from that more, but we're still there on Fridays amongst other days. So we're a lot of the time what we had done over the years was really kept moving forward with having all these students and having all these connections, but really didn't spend a lot of time evaluating it. So we've tried to spend some time over the years. So this is from 2020, really doing oral histories with students, trying to say, what is it that you're learning when you're here? And are you mislearning? Are you learning something we don't want you to, right? So most students in our program come at least once. They often come multiple times or can choose to do it for their full practicum. And a lot of the students in this first part of our exploring of their evaluation of their learning was really the self-reflection. What are my biases? How could I do better? What does it mean to be an anti-racist nurse? What does it mean to think about health equities and the social determinants of health besides what we read in a textbook? It's really connecting on a human scale, building those relationships that we've been talking about based in mutuality, and developing skills to make needed change. So a lot of times our students, we often talk about the citizen nurse, which is some of the work we've done trying to weave some community organizing skills into what we do with the students. So who's got power in this situation? How do we wrestle with how that could be different? Who might we want to explore partnering with and do a one-on-one with? How do we power map and what does that look like? And how do we really unpack this problem in a different way? Like, what are the root causes? What are the structural things in place and homogenies of power that are making this problem persist? And who's not at the table when these decisions are happening? And is there a way to change that? And so trying to get students to kind of understand that. And then we had a health equity grant through AARP and the Robert Wood Johnson Foundation that helped us even dive deeper into like what we were exploring. And so with that, we were able to work with this group called Street Voices of Change. For example, they are an advocacy group of all people who have lived on the streets. And so we go to them now for evaluating everything. We actually just evaluated our whole nursing program for our accreditation by going to Street Voices and asking them, what do you want when you show up for a nursing visit? What is it that healthcare is not providing you? And so what we did with them is we asked them, okay, we got this grant. What does it look like? And what should we be doing more of? So it was evaluating the health commons, evaluating student learning, and then also thinking about what people are naming as structural inequities that are impeding their ability to get their health goals met. And so we met with them and also had interns who worked with us during that time, as well as expanded the health commons. We did a lot with that $50,000. So with the students, we really did a questionnaire pre and post using the diversity and oppression scale. All the students were invited to participate. And then we also had interns. There were 6 different interns that did reflection journals. So with the surveys, most of the students really said that many of the people had that the statements they grew the most on was I heard many people with lived experience share their obstacles and care with me directly. I have been encouraged to think about how I could possibly create a more just and equitable society or needed changes in healthcare. I know how to decode systems of oppression that impact marginalized communities. So we did have a shift in what the students were experiencing, even in a one-time visit. So again, we had the graduate nurses who did their internships over the semester. And here's just some of their key takeaways. The magnitude of connections that they made with strangers in a short period of time was really impactful to them. Homelessness is very complex. They learned to have a strength-based mindset, dignity and death for the homeless, which we'll talk about a little bit in a second. Another one was really the impact provided in a community space and how that space can bring people together that otherwise might not cross paths, and the complexity of homelessness. I would say too, a lot of the times our students just realize, oh my gosh, these people actually don't trust nurses. We're actually helping like reestablish trust with healthcare providers because people have felt that they weren't heard when they showed up in certain moments. And then the interviews that we did with people who were living on the streets, it was kind of this crazy phenomenon because we didn't ask about trauma. And that was what came up in the most in terms of their barriers to accessing care was just the ongoing perpetual toxic stress of living on the streets, whether it was, being physically or sexually abused, um, just feeling unsafe, all the things that they go through every day, a lack of trust and safety within the healthcare system, loss of housing. So really those kind of competing priorities. This is a picture actually of a woman during that time that during the study, and she has been going to the health commons since I was there. And she was a woman who was living on the streets and she was, forced to sell herself because of her um, obstacles with substance use. And so, anyhow, she was a very vibrant individual. She even had a squirrel named Nuts that she would bring in a little cage to the health commons. But anyhow, she ended up getting beat up by a boyfriend and had some very infectious wounds. And then what ended up happening was she put next to kin down as the pastor at the church and myself. And so we were called into a care conference asking what we should be doing for this woman who is actually the same age as me. Um, and it was it's stories that it's recorded, so my husband can't know all the things that happen if he listens to this. I'm just kidding, but it was a story that had so many layers of complexity. But in the end, she ended up passing away, and all she wanted to do was see her boyfriend before she left, and she was saying that to us. So, anyhow, what we've really realized in this moment is how many people in the unsheltered community are very fearful to talk about their end of life wishes. And so we have a student right now working on their student final project to think about what does end of care life look like and how can we play a part in this at the Health Commons. And so we're going to start helping people do their end of life care wishes. And it's a whole big project we're working on. But so we have them written down, and then I don't need to be going to everyone's care conferences at end of life without really knowing what their wishes are. So all these different health commons, we'll talk about a few more, function through community academic partnerships. This is a picture of the one in North Minneapolis at Redeemer Lutheran Church. Dr. Luxercap is here. She was just there this evening. And so this is another site that has been started. I believe 2012 is when this one was started, but we've taken on more leadership in the last few years on this site. And then in 2023, we opened one in the Cedar Rivers or the east side of St. Paul. So this kind of shows a different map with all the different health commons. And so this one's at the Sane Foundation. A lot of times it's really about caring for the elderly population. So it is doing a lot of foot care and then meeting with the food access group and doing kind of collaborative care at the same time. And so these are all our different sites over the years. We did have a site in Rochester, Minnesota for a while that ended up closing during COVID, and we don't have faculty there to reopen it. And then we do have another site that is now at the Women of Nations in St. Paul, which is a domestic violence shelter for women in St. Paul. And so, yeah, you can see the grant really helped some of this grow. Um, and then what we also do in some of these spaces at other times is how they have other courses. So we have our interfaith scholars here meeting with one of our imams in the neighborhood to really understand like the health implications. And then we have some students meeting with some of our unsheltered community at Central so they can hear and ask questions about what their faith practices might be or what really is important to them. So over the years, we've had 3,000 students, 96,000 care visits, 120,000 pairs of socks, and these are probably underestimated. And then I really think the lessons that I have learned over the years is really how hard and how important it is to suspend judgment. It's so important, no matter what aspect of life I'm in, is really thinking about what that means to truly suspend judgment and try to be in the moment. Knowledge is fluid, not fixed, and really trying to be open to that. Humility is required. None of this work is done without humility. Being uncomfortable with being ambiguous. And I think this is the hardest one sometimes for faculty members because you just never know what's going to happen. If somebody is going to overdose when you're there, or, have a mental health crisis, and what do you do in those moments? Health is membership. I don't know if any of you have read Wendell Berry, but really thinking about not just the absence of disease means health, but really this sense of belonging. Letting go when things aren't working. That's another one that's hard. And knowing there's always more to it. Maybe somebody's telling you pieces of their story and it doesn't all add up, but that's okay. It is their story. And we don't have a sense of entitlement to know more until they're ready to share it with us. And a lot of this work is really grounded in the mission identity of Augsburg. And so this is our president, Dr. Paul Pribenow. He went out on the streets during COVID with me to bring out food, and he's just a remarkable advocate for this work, which we wouldn't be able to do without him. So that's what I got. Let's see if I can stop sharing my screen here.
Thanks, Katie. Yeah, your story is remarkable. Anyone have any questions or comments to start off with?
The work that you're doing is amazing. And I'm sure that there's just being able to think about all of the directions that this could go, and it's really exciting. Thank you for doing that work.
Yeah.
Thank you.
I was wondering what you've written already about this that people could see.
Sure. Yeah, we have written a lot about the model and a lot about the citizen nurse. And we've been fortunate to connect with like there's a school in Chicago area who's trying to start a health commons. Katie, Dr. Martin, where was that group from Kumu conference was here, and there's another group, was it Kentucky, that's met with us that want to start a health commons as well. So yeah, I mean, so it's kind of exciting because yeah, the more that people want to do this, the more we're excited about it. I think from my perspective, it's a place for faculty too, where it just infuses in your classroom and it infuses into everything kind of that you do. But it is hard sometimes for people to understand what it is. And so that's probably the trickiest thing with the partnership, as much as the partnership is amazing and has been flourishing for a long time, but really understanding like how do we stay committed to this authentic idea of what it means to be in a space like this, and it's because it's easily to it gets easy to maybe shift into everything needs to fit into a box and meet an outcome that the greater, whether it's, you need for a grant or you need, so we don't do a lot of grants because we try not to do things that are prescribed beforehand, because we don't know what the community will ask for. But it makes it tricky for funding.
Yeah.
I'm
Nice.
just gonna,
Oh, go ahead. Well, I was
Oh.
going to say, when this topic was going to be done, I didn't even know what it was about. So very interesting to see and to hear what this is about. Yeah, but it'd be nice to share it. And I was thinking, if you could even share it with the ANA, the whole Nurses Association would be good to share, not just with faculty and
Thank
stuff
you.
like that. It'd be good.
Thank you. I appreciate that.
Yeah, if there's an article that you could submit to ANA, to the nurse magazine, I agree with Mary. I mean, there's how many times across the country is this situation also the case? So giving a model that can demonstrate radical hospitality to the community. I mean, I already looked up on your website how to volunteer, because it just seems like
Yeah.
the right place to be doing the right thing.
That'd be amazing. We love it, having volunteers and other schools too. So Dr. Hines is here. I know we've talked about having some St. Thomas students and how fun that would be to collaborate on something like this, because we need each other. And right now, I think we need each other more than we ever have. And so, what does that look like? And I think some of this work, like, I mean, some of the things that we've been able to do in the department just based on accreditation processes in the last year with 3 different chairs in 1 year. And I landed on the short stick, only one still tenured. So here I am, the chair. But, we've been able to change the whole curriculum and all the grad programs and undergrad program in 1 year. And I think a lot of it has to do with the bond that we have because we're in these moments together where we really trust one another and know each other in a different way. So, and some of this stuff, when you see somebody die or you lose somebody in the community or you respond to somebody overdosing, there's just, it's real, right? And it changes you.
I have a question. It's more of like a logistics question. I'm doing research for St. Ben's with their undergraduate nursing program, and I'm working on helping research for a community outpost clinic. And I was wondering, I don't know if I missed this, I was having trouble getting on the Zoom, but if the orientation for the students who go is only in the classroom, like paired with their upper level, like undergraduate nursing classes or graduate nursing classes, or if there's like orientation that they go through before getting to go to the site.
Yeah, that's a really good question. And so I think I'm a fierce advocate of the fact that you need to have, well, I probably don't do the best at so you have in the classes that you come, you watch like a voice thread. So you're kind of aware of what's happening. Because when I first started, people would show up and they'd be like, wait, I'm working with the unsheltered community. Like no one told me. But plus, like, we don't want anyone bringing their stethoscope. You wear street clothes, like try to even think about what you're wearing and how like that might signify that maybe it can put you at a power differential, right? So like if I come like I'm dressing like I'm the chair of the department versus wearing street clothes, that's going to maybe break down some barriers in the communication right off the bat. And so trying to have some of those conversations, but what I might wear in the Cedar Riverside neighborhood would be totally different from that, right? And so what are those cultural norms? How do we show up? Where do you park? Do you have security? All these things. Yes, we do that in a voice thread. And then we always debrief. So debriefing is the most important part. I will not take students if I cannot debrief because that it can, again, you don't know what stereotypes you might be reinforcing. And then you want to make an open space for students to say whatever is on their mind, so you can really have those conversations. Dr. Luxerkamp came from St. Ben's, by the way. And so she came as a student, and that's when, we have to always ask if a student in particular, like Brooke had to do so many hours with us, that could she take up that space with our other students, and she's exceptional. So of course she could. And so now we've hired her. So.
And I love the Health Commons so much. That's why I wanted to come back there. And Mary Pesh is on the call, who was my professor. So it's a small world.
Right. She was an exceptional student, and I'm sure she's doing great things for you there.
Yeah, she is.
I have two questions.
Yeah.
First question is, what does volunteering look like with the organization? I'm assuming that people that can have some repetition would be most beneficial. So different forms of volunteering. And then also, what does funding structure look like for you guys?
Sure. Yeah, no, we don't have any requirements on any of that. Usually Central is the easiest location. So if you go to our website, there's signups for all the different locations. And you can always email me too, but usually Central's kind of the place that people start. It's kind of the easiest, the most need. So it's the kind of easiest to get an idea of what the model is and how to respond. And Cedar Riverside on Fridays as well is very busy as too. But and then in terms of funding structure, it's tricky. And so Central, I had no idea. I was still a grad student when they told me I should apply for this job. I had been working with homeless youth. So I spent the majority of my master's project working at the Bridge for Youth. And so they were like, you should apply for this position. I'm like, okay. I thought I'd just be like at the Health Commons 1 or 2 days a week and still working at the hospital 0.6. And then all of a sudden they're like, oh, you have to fundraise and you have to get the supplies and you have to write annual reports. And what? Like I had no idea, right? And so yeah, so now we have an endowment. Actually, a previous student started an endowment for us that makes some money every year, and then we do give to the max, but Central is literally whatever money we get is the money we have, and if we don't have money for supplies, we don't have money for supplies. And then a third of my position is funded by Augsburg. Which is always on the chopping block for all of you in higher ed, as you know. Those are the extra, depending on who's the provost and the president. And then we do have a grant that helps faculty get paid for the other locations. And then the Fairview Foundation pays for the majority of the other things. We started with the UCare grant for 3 years, $50,000 for Cedar Riverside, but Fairview's the main financial. I said, there's no way I can do all the finances for all these sites. And thank God I had no idea I'd end up being chair a year later after we started a majority of these. So, and thank God for my colleagues, or we'd really be in trouble.
Cool. Thank you.
Yeah, anyone's welcome to come.
Right. So following up on that, so you, in your role, you have one third of your role is in this. And then so our other faculty, do they get released to be in the place, or it's a additional responsibility on top of?
So every year looks a little different, as you probably can guess. So this upcoming year, it's mostly grant funded. So it's like they have a position outside of Augsburg and I'm paying them through the grant by the hour when they're there. That is not the ideal structure, but they keep cutting different things. And so, yeah, but every year's a little different. I mean, when we started, we had multiple people for one site, but it's not the world we live in anymore. But the university is so supportive. I can't complain about it. Like they really uplift us in so many things. And actually the Health Commons is part of the Mission Identity Division. So we've been helping, or I've been lucky enough to help write books about the university on their community engagement, and just did another one where I had a student and I looked at the history of Augsburg through like a racial or a racism lens. And so what wrongs can we commit to rectifying? And so that was a really great project to do it was a Somali student too. And so the university in that way is very much supportive of what this work is. And when I first started, only nursing students could be a part of it. And now we have social work students, PA students, we have PA faculty, we have undergrad students. So we don't limit that. And actually, usually the students who have not been in a professionalized environment get it easier, especially some of our like critical race majors or the interfaith scholars, and we have other interns and things like that in undergrad programs. Because Augsburg is now, I don't know if many people know this, but we're the most racially diverse campus in the Midwest. And Lavender Magazine has named us the top 5 transgender friendly campuses. So we, our campus looks a lot different than when I started because of this commitment to intentional diversity and caring for communities that maybe weren't able to access higher ed like they can now. Hopefully it stays that way.
Julia had a comment in the chat, and Julia, I wonder if you want to talk about that, if you can. I think she's also doing clinicals.
Oh yeah. Yeah, so we haven't gone to East Africa. We do have an immersion program that our students can choose to participate in. And we go to Namibia and we go to Guatemala, we go to Mexico and Italy. And then for our DNP orientation, we all take a trip to the Black Hills, and some of the local elders will come and share with us some of their key lessons that they want to teach us about Indigenous health practices. We used to go to Pine Ridge, but we've had to put that on pause the last year just from faculty time constraints. But so we do have a pretty good global immersion program for all of our nursing programs. But we could always look at doing more. But that's kind of the problem. We all want to do more, but we don't want to have more immersions than we have students. So. But I've been to Tanzania, so in East Africa, and I'd love to go back and think about bringing students.
Do any of those trips, are any of those open to community members, or are they only for students?
We have right now we've opened them up to alumni, and we've talked about if we would there's always this like struggle of like, will people go and make it a trip and not pay attention if they don't have to take the class? But I think we're trying to explore that too, because the more people we have, the cheaper it is for our students to go too. And so, yeah, not yet, but maybe someday.
Sure.
Or you can just come take a class at Augsburg in your free time as you're eliminating stand with your kids and
yeah.
Yeah. Mm-hmm.
So I used to go to Augsburg in 2004 to 6, and then ended up with the because at that point there was no undergrad bachelor's in nursing, so it was through ACTC through St. Kate's. At the time I would have needed to wait probably 2 to 3 years to even be accepted into that program, with the wait list that St. Kate's had. So I went other routes, and I got my LPN and my 2-year degree and things like that. So not a full alumni, but have taken some classes at Augsburg, or 2 years at least. So I don't know if that would count or anything. But.
Well, yeah, email me and I'll talk to everybody when we all get back and see if we have space. Yeah. Our first Italy trip is going to be this year to the Blue Zone. So we're taking a different angle than like this social justice stance, and really trying to think about, what is this healthy
food is medicine. Yeah.
Food is exactly.
Yeah.
Slow medicine, they're calling it.
I have another question. How do you go about tracking the amount of patient interactions you have and the cares you provide when you are dealing with populations that maybe can't answer some of the identifying questions? Maybe they don't want to, they don't know the answers to all the questions that you would typically be asked when having a sort of like doctor, nurse, any patient care interaction?
Yeah, that's a great question. So with the amount of people, it depends which site you're at. I would say most of them, it's pretty doable to count because the numbers are kind of low and people not low, but 20s, let's just say, and you can kind of get a gauge of who came in, and some people might repeat. Let's just say Central though, where we have a lot of people. We do our best to there's a clothing closet or a free store, and they take numbers. And so we always say we take a glimpse. So we used to do it by socks because we would run out of socks every single time. But now that Bombas gives us socks, we can give people more than one pair of socks. So it's really hard to track. But what we do is go with the clothing closet number and then estimate how many more people, usually more people come to us. So we know at minimum, let's say on Monday, I had 45 at minimum come through. And then when people come and ask to meet one-on-one with a nurse, and maybe they want a cough drop, or maybe they want muscle rub, or maybe they need a Band-Aid or wound care, then we have this tracker. So we used to write soap notes when I started, and we had just cabinets full of notes, and everybody would tell us a different name when they came in, and we'd spend all these hours doing notes, and then we'd put it in an Excel spreadsheet, and we'd be there for 3 hours. Like, what are we doing? So now we just have this scratch sheet that when you say the same data you would have before, so the same kind of stuff over 90 since 1992, like how many people came in, kind of did you educate, did you do any wound care, kind of an estimate of their gender, their age, and their living situation. And some of it we know, and sometimes we make our best guess, but we say that in our reports too. And usually we get to know people over time. So it might be not the same people every time that come in, but they cycle. So it's kind of like you get to know them really well and their story and their circumstance, and they're pretty open about sharing things. And so we do the best we can, but it's not perfect because we don't sit down and ask those questions right off the bat. Mhm. And so it's hard too, but we say that to all of anybody who we do a grant with, like, this is how we're going to do it. And we have come up with ways for food, some of the food things, but some of the food places that we wanted to partner with, we ended up just saying no because they asked so many personal, like even personal stories they wanted. Or sometimes we partner with people and then maybe their like mission doesn't align with how they view, if I grew up Catholic, and so there's lots of different ways of being Catholic, right? But some people really want to make sure that they talk about their Catholic faith in those moments, which doesn't really, we can't have something be forced upon people in a situation like that. So as long as we all commit to the same ideals, but you kind of have to be really protective of who you partner with too, because you bring in the wrong person and you could ruin your trust pretty easily. So we've had to make some really hard decisions where we might have been able to get some really good services, but we just knew that it might not land in the community the way that we wanted to, and could move us backwards from where we've come over the years.
Yeah.
Thank you.
Yeah, you're welcome. And Brooke, Katie, anything I should talk about that I didn't say?
And just a thank you to you, Katie. So inspiring what you're doing. And in these days of dashboards and data and outcome, just to remind us that we're in this because we want to connect with people. And it's about relationships, building trust. And I think a lot of the things that you said, I mean, they really work in any setting in nursing. They might be a little bit more difficult, sometimes within the institutions and everything. But when we think about our relationships with people, how we have to suspend our judgment, meet people where they are. I think those ideas just transcend like all our interactions as nurses. So I just love hearing about what you're doing. Look forward to partnering. Thank you.
Thank you. Thanks for coming. Yeah, and I think too it helps with our students. Like we're with our students in these moments, so we establish this whole relationship with students that I think is really powerful too. I've only had to kick a student out once because he just was not he thought homeless people were working the system and didn't have a lot of compassion for them, which is okay. He can have that feeling, but just the way it was being expressed was kind of like, I don't think this is good for our guests, and I don't think this is really helping you in this moment. So it's okay if you want to go home. And so he was from Rochester, but and that's okay. So just being open too, that sometimes you gotta have hard conversations and not suspend judgment in that situation too, because who knows what their experience has been.
Katie, have you been able to follow any of the students over time to see what the impact of this has been on their career?
Oh, yeah. I mean, well, say there was a lot of us who went through the program that ended up working being
Yeah.
faculty members and not being able to leave. But yeah, no, I have had students who say that it has definitely changed, and we hurt ourselves that we don't write some of this down, but really, like, Dr. Martin had a student who was an intern that really wanted to get this dream job working on health equity, right, Kate? And she got the job because of the recommendation she got from the Health Commons, but she felt like because of what she was exposed to at Augsburg, that really fueled her passion to being able to want to do something different. So that was something just real recent. The internships really impact the students, I think, a lot, but it's hard to get the money to do that. And then a lot of them want to end up teaching too.
That's good.
Yeah.
Oh yeah, soul care. Yeah. I did my certification with soul care for the souls. They're awesome. Yeah. And they do really good foot care. Not like us. We just do more foot soaps.
Any other questions or comments?
Yeah, this is Rachel. Sorry, I've got my phone on. So we've got a health commons that we use like at MSU Mankato, but it's located it's a health commons at Pond. I can't remember. I think it's Edina maybe. And it's located in one of the schools. And I don't do much with it since I'm only in the pre-licensure program and it's more for our graduate students. But do the health commons do they like communicate at all? Or
Sure.
are they
That's a good question. So the one at the pond, when I was brand new, so it must have been 2011, 2012, they did come up to
okay?
Central and meet with us because they wanted to use the name and think about replicating the model. I think the model looks a lot, I don't think they use the model as much as just the name, which that's just fine. I think they have a lot more funding and things too. So, but no, we were connected at the beginning, but I haven't done a good job of keeping in touch. But I email every once in a while with that faculty member that had reached out. But yeah, that's a good thing we should probably do. Yeah, but
I was just curious if they were connected at all. Because our students, every once in a while, we're able to send some undergrad up there, and it's really helped get, like you had mentioned, reshape some of their lenses, because sometimes they just think that, hospital nursing is the only thing in nursing, to reshape their lens of what is out there, especially this, like you mentioned, those that are really interested in social justice and, disadvantaged population. So I found what you were presenting on, very, very relevant. And it's nice to know. I didn't know there was another one. So
yeah. So they were really great about asking permission, which it's not, it is what it is. Like we don't own it, but also it seems to be something impactful for the community. So if there's more of them, that's great.
All right, if there aren't any more questions, it's just exciting the work you're doing, Katie, and writing down all these like, oh, you need to know about this, or I should connect you with this person or that person. So, Katie is going to be the MNORN's American Nurses Advocacy Institute Fellow for this year. So, so it's
really excited. Yes.
Nice.
Yeah.
Good.
So anyway, it was
What a year to be doing that.
exactly.
Well, thank you so much. And thank you for everything that all of you do for all the people in the world and for, I always get most nervous for nurses sometimes to present because, I don't know why, but I do but it's been wonderful. So thank you so much for being here.
Thank you.
Good.
Yeah, thank you. It was wonderful.
Thank you. Good.
Have a nice rest of the evening, everyone.
Yes, you too.
Night, everybody. Thank you, Katie. Fabulous.